Very good morning to all of you, and welcome to the teaching session of Department of Urology, Savai Man Singh Medical College, Jaipur. Today, we have a teaching session on etiopathogenesis of renal stones. We know stones have been forming in humans since time immemorial. We have Egyptian mummies about 7,000, 8,000 years old who had stones in bladder and kidneys, and still remains quite a big problem. So today we will discuss on the etiopathogenesis of renal stones. The presenter would be Dr. Rahul Singh, and this would be moderated by Dr. R.D. Sahu. So today we have an expert faculty with us, Dr. S.K. Singh. He doesn't need much of an introduction. He is professor and head of the Department of Urology at PGI Chandigarh. He has been academically very sound. He has written more than 300 papers, many chapters in books. He has been awarded multiple times with various orations and Duskon Awards. And he has been also the member of governing body of Indian Council of Medical Research. He was our honorary secretary of Urological Society of India. He had been the president of North Zone chapter of Urological Society of India. He is now the executive member of World Uro-Oncology Federation, and is also the editorial board member of Indian Journal of Urology and British Journal of Urology International. So thank you, Dr. S.K. Singh. So we may hope that he
morning. Yeah, good morning to all of you, Ji.
Okay, thank you.
Nice. Very nice that you have got so much program and then making everybody, again, fruitful and useful. That's a very good thing. And I'm very happy to join you as a teacher. And I know your sophistication and precision. I can see that one in the photograph, right? So I think we can, so we can start now.
Thank you, sir. Thank you. Thank you for joining us. We know you have a lot of research work in stone disease also. So it's really a pleasure to have you with us today in our teaching session. So now I would request.
I am joining on, I will say, on another desktop.
Okay, sure. You just.
So just I am opening that. So I thought I should not be delayed. So it was taking time.
Thank you.
So maybe 1 minute. Within 1 minute, I am joining there.
So RD, please invite our presenter and start the presentation.
Thank you, sir. I welcome on behalf of the department, Dr. Rahul. Please share your presentation, please.
Morning to all. Today I am presenting a presentation on etiopathogenesis of renal calculi. For epidemiology, overall prevalence of renal stone is around 1 to 5% in Asia. Recently, there has been increase in the incidence of asymptomatic stones due to increased use of better imaging modalities such as CT. About gender and age, the renal stones are uncommon before 20 years of age, and most common age group is for 4 to 6 decades. Males are around 3 times more affected than females, but the gender gap is narrowing. In women, there are bimodal distribution, and the second peak corresponds to the onset of menopause. About geographical risk factors, they're more common in hot, arid, and dry climate and seasonal variation, more in summer, and this is because of high temperature and sunlight induced increase in vitamin D. About diet and metabolic association, decreased risk of stone formation are found in high fluid intake and low protein intake. Increased risk is found in obesity, metabolic syndrome, which includes hyperlipidemia, hypertriglyceridemia, hyperglycemia, and or hypertension. Type 2 diabetes mellitus is associated because of high urinary oxalate and low urinary pH. About pathogenesis, it includes in 4 stages: supersaturation in urine with stone forming salts, then crystal or nuclear formation, then anchoring of crystal and aggregation, and finally leads to stone formation. What physiochemistry? Stone formation begins with supersaturation of stone-forming salts in urine, which precipitate and form crystal nuclei. Crystals may flow out with the urine or become retained in the kidney and anchoring sites that promote growth, aggregation, and ultimately leading to stone formation. State of saturation, nucleation, crystal growth, aggregation, and retention, inhibitors and promoters of crystal formation, and finally matrix. One slide about the concentration product. A solution containing ions or molecules of a sparingly soluble salt is described by the concentration product. And concentration product formula is, for example, from sodium chloride is sodium into chloride. Saturated solution. Pure aqueous solution, when it reaches the point at which no further added salt will dissolve, is known as saturated solution. Solubility product, the concentration product at the point of saturation is solubility product, and formation product at the concentration product increases. The point at which the solution can no longer be held in solution and crystal form is known as formation product. States of saturation in urine. Under saturated stages below the solubility product, crystals will not form. In the metastable stage, it is between the solubility product and formation product. It is in this area, modulation of factors controlling stone formation can take place and therapeutic intervention is directed. And in unstable state, at concentration above formation product, crystals will form. Homogeneous nucleation, process by which nuclei form in pure solution, and heterogeneous nucleation in urine. Crystal nuclei usually form through heterogeneous nucleation by absorption onto surfaces of epithelial cells, debris, or other crystals. Crystal growth. Inciting event in the pathogenesis of stones by vascular injury to the vasa recta near the renal papillae. Repair of damaged vessel wall results in calcification of endothelial wall, followed by erosion into papillary interstitium, and then into the collecting ducts, which serve as a nidus for stone formation. One slide about Randall plaque. The origin is in the basement membrane of the thin limb of the loop of Henle, and the plaque subsequently extends to a subepithelial location. Initiating event is a vascular injury to the vasa recta near the renal papilla. Repair of damaged vessels results in an atherosclerotic-like reaction, which causes calcification of endothelial walls, ultimately erosion into papillary interstitium, and then into the collecting ducts, which serves as a nidus for stone formation. There are some inhibitors in the urine, molecules that raise the level of supersaturation needed to initiate crystal nucleation or reduce the rate of crystal growth or aggregation, and hence by preventing stone formation from occurring on a routine basis. The inhibitors have been identified for calcium oxalate and phosphate, but no specific inhibitors are known to affect the uric acid crystallization. There are a few common inhibitors: inorganic pyrophosphate, citrate, magnesium, polyanion macromolecules, urinary glycoproteins, osteomontin, urinary prothrombin fragment, and bicunate of intern alpha trypsin. Citrate, inhibitors of calcium oxalate and calcium phosphate formation. It acts by three mechanisms. It complexes with calcium, thereby reducing the availability of ionic calcium. It prevents spontaneous precipitation of calcium oxalate, and finally, it prevents heterogeneous nucleation of calcium oxalate by monosodium oxalate. Nephrocalcin, it is synthesized in the proximal renal tubules and the thick ascending limb. It inhibits growth, nucleation, aggregation. Inorganic pyrophosphate, it is responsible to around 25 to 50% of inhibitory activity of the whole urine, again calcium phosphate crystallization. Hosphoprotein, it is the most abundant protein expressed by the renal epithelial cells in the thick ascending limb and the distal convoluted tubule as a membrane anchored protein. It is a potent inhibitor of calcium oxalate monohydrate crystal aggregation, but it does not affect the growth. Its function varies according to urinary pH. In alkaline urine, it acts as an inhibitor, but in acidic urine, it polymerizes into a configuration that promotes crystal aggregation. Matrix. Renal calculi consists of both crystalline and non-crystalline components. The non-crystalline component in its term is matrix. It is around 2.5% of the weight. It includes 65% proteins, 9% non-amino sugars, 5% glucosamine, and 10% bond water, and 12% organic acid. The main proteins are phosphoprotein, nephrocalcin, renal lithosterin, albumin, glycosamine, glycans, and mucoprotein matrix substance A. The substance A is immunologically unique and present in the matrix component of all stone formants. Now about mineral metabolism. Calcium. Calcium, around 30 to 40% of dietary calcium is absorbed by the intestine in ionic state. The absorption of calcium is by two routes. In non-saturable state, it is by paracellular pathway. In saturable, by vitamin D dependent transcellular pathway. Substances that complex calcium absorption are phosphate, citrate, oxalate, sulfate, and fatty acids. Role of parathormone on calcium metabolism. The decrease in serum calcium increases parathormone secretion. Parathormone stimulates 1,5-hydroxylase, which is located in the mitochondrial proximal convoluted tubule. Transcellular calcium absorption is mediated by calcitriol. Parathormone has no direct effect on intestinal calcium absorption. Oxalate. 6 to 14% of ingested oxalate is absorbed, mainly from the small intestine and 50% from colon. Small bowel disease or intestinal resection with an intact colon leads to increased absorption of Markle of colon. Absorbed oxalate is nearly completely excreted in the urine. The pathogenesis of upper urinary tract, stone composition occurrence. Most common are calcium oxalate stone, which comprises about 80% of all stones. And most commonly is calcium oxalate 60%, hydroxyapatite 20%, and brucite 2%. And remaining are non-calcium oxalate containing stones, mainly including uric acid and struvite stones. Calcium stones, the causes are hypercalciuria, hyperoxaluria, hyperuricosuria, hypocitrate urea, low urinary pH, tubular acidosis, and hypomagnesuria. The most common is hypercalciuria. It is defined as more than 200 milligram of urinary calcium per day after taking 400 milligram of calcium and 100 milligram sodium diet for at least 1 week. The three types of hypercalciuria: absorptive hypercalciuria, most common, accounting for 55% of the cases; renal hypercalciuria; and resorptive hypercalciuria. Absorptive hypercalciuria, there are two types. Type 1 is when the urinary calcium remains high despite a low calcium diet, and in type 2, urinary calcium normalizes with a restricted calcium intake. Renal hypercalciuria, the kidney absorbs normally more than 98% of the filtered calcium. Impaired renal tubular reabsorption of calcium salts in elevated urinary calcium level causes secondary hyperparathyroidism. High fasting urinary calcium levels with a normal serum calcium are characteristic of renal hypercalciuria. Resorptive hypercalciuria. Resorptive hypercalciuria most commonly associated with primary hyperparathyroidism. Excessive parathormone secretion leads to excessive bone resorption, increased renal synthesis of vitamin D, and intestinal absorption of calcium. It also causes hypercalcemia and hypophosphatemia. Hyperoxaluria. Urinary oxalate greater than 40 milligram per day leads to increased saturation of calcium oxalate. Membrane injury facilitates the fixation of calcium oxalate crystal and subsequent crystal growth. Causes of hyperoxaluria. Primary hyperoxaluria, there are two types: enteric hyperoxaluria and dietary hyperoxaluria. Most common being enteric hyperoxaluria. It's most common found in chronic diarrheal states, which causes fat malabsorption, saponification of fats with fatty acids with calcium and magnesium. It reduces calcium oxalate complexation and increases the pool of available oxalate for reabsorption. Hyperuricosuria. Urinary uric acid exceeding 600 milligram per day. At pH less than 5.5, the undissociated form of uric acid predominates, which leads to uric acid and/or calcium oxalate formation. At pH greater than 5.5, sodium urate formation promotes calcium oxalate zone formation through heterogeneous nucleation. Hypocitrate urea. Urinary citrate level less than 320 milligram per day. Hypocitrate urea is an important and correctable cause of stone formation. Isolated abnormalities found around up to 10% of calcium stone, and in around 20 to 60% cases is associated with other abnormalities. Now, role of urinary pH. At low urinary pH less than 5.5, the undissociated form of uric acid predominates, which leads to uric acid or calcium stone formation. Struvite stones are commonly found in alkaline urine. Chronic metabolic acidosis can lead to low urinary pH, hypercalciuria, and hypocitrate urea. Acidosis also increases bone reabsorption and produces renal calcium leak. Now, renal tubular acidosis. It is a clinical syndrome which is characterized by metabolic acidosis resulting from defect in renal tubular hydrogen ion secretion and urinary acidification. Mainly, there are three types. Nephrolichasis is common in type 1. Uric acid stone. The three main determinants of uric acid stones are low urinary pH, which is most common factor, low urinary volume, and hyperuricosuria. At pH around 5.35, half of the uric acid present in urate stone, half as the free uric acid. The free uric acid strongly determines the risk of stone formation. Causes of uric acid stone. One is congenital disorder, which is renal tubular urate transport or uric acid metabolism defect. In acquired causes, there can be chronic diarrhea, volume depletion, myeloproliferative disorders, high animal protein intake, uricosuric ducts, and idiopathic causes. Cystine stones. Cystinuria is an autosomal recessive disorder characterized by defect in intestinal and renal tubular transport of dibasic amino acids, resulting in excessive urinary excretion of cystine. The main contributor to cystine crystallization is supersaturation because there is no specific inhibitor of cystine crystallization in the urine. Poor solubility of cystine in urine leads to precipitation of cystine. Now, about infection stone, magnesium ammonium phosphate or struvite or calcium or carbonate appetite. Infection with urease producing bacteria is a prerequisite for the formation of infection stones. The process of ureolysis provides an alkaline environment of pH of more than 7.2 and sufficient concentration of carbonate and ammonia to induce the formation of infection stones. The most common urease-producing pathogens are Proteus, Klebsiella, Pseudomonas, and Staphylococcus species. Infection stones comprise around 5 to 15% of all stones, and they are found in women twice more common than in the men. Ammonium acid urease stone, represent less than 1% of all stones. Children in endemic areas are dependent on a cereal-based diet that is lacking in animal protein, especially low cow's milk. Other causes being laxative abuse, recurrent urinary tract infection, recurrent uric acid stone formation, inflammatory bowel disease, and allostomy bowel diversion. Xanthine and dihydroxyadenine stone, they are rare. They are often confused with uric acid stone because of their radiolucency. They are commonly found in inherited disorders, enzyme xanthine dehydrogenase or xanthine oxidase defect, which converts xanthine to uric acid. Xanthine is poorly soluble in urine. The high levels of xanthine accumulate in hydrogen deficiency leads to xanthine stone. Now, matrix stones. Stone compounds predominantly of matrix are rare. They are radiolucent and can be mistaken for tumor or uric acid stones. The matrix components of calcium stones comprise 2.5% of dry weight of the stone, whereas pure matrix stones may contain up to 65% protein. Medication-related stones. Drug-induced stones form either directly due to precipitation and crystallization of drug or its metabolite, or indirectly by altering the urinary environment, making it favorable for metabolic association. Drugs such as loop diuretics, furosemide, acetazolamide, topiramate contribute to calcium stone formation. Other drugs being ephedrine, trimetrine, silicate, indinavir have also been associated with stone composition of the drug itself when consumed in excessive amounts. Now, take-home message: urinary tract stones are common in males, but the gender gap is narrowing now. Etiology is a complex and multifactorial process, including intrinsic such as age, sex, heredity, and extrinsic factors such as geography, climate, diet, mineral composition, and water intake. These factors include hot and dry climate, obesity, metabolic syndrome, etc. Urine must be saturated to form stones. There are various urinary inhibitors present in the urine that inhibit crystal nucleation, growth, and aggregation. The calcium-containing stones are the most common, 80% most common being calcium oxalate stone. Thank you.
Thank you, Rahul. I would request now RD to kindly invite Dr. S.K. Singh for his comments.
Unmute kariye, Dr. Sahu.
Muted, you are muted.
Good morning, sir. Please.
Good morning.
Sir, please enlighten us with your vast experience, sir. Please.
Yeah, thank you, Dr. Sahu. I have seen you that you are the person, stone man of SMS. Dr. Shivam used to say, sir is working for a long time. I think more than Dr. Shivam. He is spending in SMS, Dr. Sahu working in Epidemiology for a long time.
So yeah, 2014.
Yeah, so now I think I am very much privileged to join all of you and getting the honor of being the expert for stone. Yes, actually, this is the area where not lot of people have not worked. Actually, the prevention you can apply only when you know the etiology and pathogenesis. Dr. Rahul C has very comprehensively has gone through all the etiology, but yes, as an expert, I would like to highlight something more, like primary hyperuria. Then he has described two types. When the type 1 is a autosomal recessive disease, and in that case, the calcification occurs in all soft tissues, and liver transplantation is also required when the patient develops ESRD. ESRD, when the patient develops ESRD, along with the renal transplant, liver transplant also need to be done, simultaneous both. But when there is a type 2, the liver transplant may not be required, only renal transplant is required. Regarding the, again, pyridoxine, which is available, whenever there is hyperalbuminuria, they used to prescribe pyridoxine. There has been, again, some publication from the scientists that pyridoxine deficiency can also lead to hyperalbuminuria. And when you give high dose of pyridoxine, that also helps in, again, metabolism by ovulate, conversion into, again, oxalate. So that point I would like to highlight. Second point I would like to tell is the host factor, many other host factor like genetic constitution. Why it is more common in western, northwestern region of our country? Now, whether this is the genetic constitution is different or environmental factor is different, I think this has not been answered as yet. Like the genetic factors, which usually the region they forget whenever the expert do ask, can you tell us the genetic factor which predisposes these people for stone formation? Usually because that it has not been described extensively, so they forget to mention those genetic factors. What I would like to highlight is, like vitamin D receptor gene, there are polymorphisms, many genetic mutations and combinations are known for that. And then is the chloride channel gene. And one gene is called clothogene, which we have published recently. These are involved in stone formation. These people who have got some genetic constitution polymorphism in them, they are more predisposed for stone formation. But usually this is a part of only academic work. What I would like to tell that urine is not a simple solution. It is a very complex solution. And this is, you cannot do combination and permutation to say that hyperuricosuriya will lead to stone formation. As you have mentioned, Dr. Rahul, the pH is another important factor. Why the patient who has hyperuricosuriya, why they develop calcium oxalate stone? That's another important point, which usually the examiner, they ask the resident to see their concept. You have nicely described that this is due to heterogeneous enucleation. Earlier we used to call it epitaxy. Epitaxy is a lattice structure of the crystal of oxalate and uric acid is like this, is such that they fit into each other very nicely. And there will be crystal aggregation, crystal enucleation, and stone formation. The term is called hypersaturation. You have actually described hypersaturation. Then after there is a factor called crystallization. Then there is a crystal aggregation, then nucleation, and then that forms the stone. Etiopathogenesis stone starts from that level. Again, what point I will like to tell regarding the fluid intake. The fluid, usually we ask the people, okay, take enough water. We have a publication, I will not go through that, but I would like to refer to you. There's an review article in Indian Journal of Physiology, which we have written in 2012. We have written the consensus and controversies in fluid intake. What type of juice is important, which type of, drinks and beverages is again going to cause, inhibition or promotion of stone formation that we have described very critically. But again, there's no clear-cut guideline can be given about that. That's why the people do advise you make more solvent. Quantity of the solvent should be more so that crystallized supersaturation should not take place. So what advice the regent used to, that you are supposed to give, or any urologist is supposed to give to the stone former is, take water intake that they should go to toilet every 3 hours. Not that they take in the morning and whole day they keep themselves dehydrated at night. So they have to take it periodically. Therefore, there should not be any instances, any step of supersaturation. Now, I would like to mention another advantage for the resident is nanobacteria and Oxalobacter formigenes. We have a landmark publication on nanobacteria in 2004 and in 2006, which has been cited also very extensively. So nanobacteria is a nanoparticle which is coated by apatite, calcium phosphate, and it has been found that Renal plaque again has been revived in etiopathogenesis. That Renal plaque contains the oxalate apatite, and many of the nanobacteria, many of the scientists they have detected nanobacteria in there. Nanobacteria also has been implicated in atherosclerosis. So again, second point I would like to tell you, Oxalobacter formigenes. Usually the oxalate get metabolized in the intestine of the human being by Oxalobacter formigenes, which is a common commensal. So whenever because you have told diabetic oxaluria is one of the risk factors, it's a very common cause of hyperoxaluria. So that's why then I would like to tell that Oxalobacter, when it is deficient in the bowel, in the fecal flora, then those people are more prone for stone formation. There has been one publication from HGPJ Lucknow on again Oxalobacter formigenes. Earlier, one of our alumni published in Lancet, and then this was found to be again one of the bacteria, again Oxalobacter formigenes, which may be again implicated in stone formation. When the people take some antibiotic for some other cause, Oxalobacter may be deficient, and in that case, the patient becomes prone for that. So that's why in cases of hyperoxaluria, people do prescribe pyridoxine as well as Oxalobacter formigenes capsule, so that it can help in prevention of hyperoxaluria. Now, uric acid stone is different. Why to do metabolic stone? Again, analysis of stone. Chemical composition of stone is an important factor to direct the clinician in which direction you should investigate this patient for any cause, underlying cause. Usually when you do extensive metabolic workup, which is lacking, because this is not cost effective. Usually now treatment is so easily available, so modalities of treatment are available that people don't investigate these patients for stone formation, even they have formed stone again and again. Reason is yield is very low. That's why they don't do it. And it is very costly also and not available at many centers. So I think with that comment, I would like to tell the CR resident must read what are the genetic factors of the stone. Again, they should read what is hyperoxaluria, because this is usually people are curious to know. And then to just highlight about, I have told you about Oxalobacter and about nanobacteria, because these have been implicated in stone formation. Regarding the fluid intake, I have emphasized it should be indicated periodically. And water intake, yes, so that patient should go to toilet every 3 hours or so. So to maintain hydration periodically. And potassium citrate also is an important, again, preventive measures which usually people do prescribe. So it is important to know etiopathogenesis and the stone formation, so that the clinician, urologist should apply it to prevent stone formation in their patient whom they are treating. So I think if there is some query and questions, I can take it further. Otherwise, I think I have done.
Thank you, sir. Thank you very much for those wise comments. And I think a lot of things need to be still researched on. And what you said about the hyperoxaluria, I think that's very important in the sense that we often miss this kind of investigation. So if the patient is having hyperoxaluria, we should go forward and do a genetic analysis. And as you said, it could be of multiple types, pH 1, 2, and 3. pH 1 probably requires a liver transplantation also along with it. And the role of pyridoxine in these patients, again, it's very important, as you said. Then you told about the genetic predisposition. I think that's very important. Many of these patients are predisposed genetically, and the role of vitamin D receptor polymorphism, then the channel gene and the fibroblast growth factor polymorphism, and then another thing is the intestinal oxalate transporter polymorphism that has also come up. So all these probably are important, in stone formation. Then you told about the value of pH, how important it is in stone formation, and the fluid intake. Yes. So fluid intake, it's not just taking the total amount being 2 to 3 liters, but how regularly you take it and how regularly you pass urine. That is again very important that you stressed upon. Supersaturation, the ultimate probably pathology is the supersaturation, and then crystallization, and then nucleation, and then stone formation. So there was one article recently which I studied, which read like upstream mineralization in the tubules, which leads to downstream mineralization in the interstitial tissue, resulting in Randall's plaque formation and then further stone development. So I think these things are very interesting. And then you also highlighted on the bacteria, and you have your own research work on Nanobacter formigenis, which may be responsible for kind of some atherosclerotic vessel damage and resulting in stone formation. Oxalobacter formigenis, we all know about the importance of it in calcium oxalate stone formation. And so patients with these stones can be benefited by giving these oxalobacter and pyridoxine. And lastly, the metabolic evaluation. That was again very, I think we are all, most of us are missing metabolic evaluation of these stones. And we started a lot of times doing metabolic evaluation. Then again, as you said, the problems of not being available everywhere. Secondly, the cost factor. All these probably are hurdles in doing a metabolic evaluation. And another thing that I feel is, and I would really ask you also regarding this, how beneficial it is. Like we know almost most of these cases are idiopathic still. We do not know exact cause. And in how many cases do you exactly find out the exact cause, and that helps you in guiding the treatment in metabolic evaluation?
Very rightly told, Professor Sivam, that how extensively one should investigate these patients to gain the benefit. In that context, I would like to tell that calcium, the basic metabolic work must be done in all patients, whether they have got primary, they are a first stone former, or they are a recurrent stone former, because there could be around 3 to 4% of people who can be prevented to have stone formation again, like hyperparathyroidism. When we have a study which we published also in 2016, that in northwestern India, the hyperparathyroidism prevalence may be up to 3 to 4%. Only that, how do you investigate? So patient must be investigated for serum calcium, phosphate, alkaline phosphatase, protein, as well as for hypercalciuria. Yes, most of the time this doesn't yield much result, and we used to take a measure, a common comprehensive measure like fluid intake and citrate, potassium citrate. But many people, they don't like to continue potassium citrate for a long time. So I will say that calcium should be done, serum phosphate should be done, sodium potassium chloride. That we will be one of the indicator for finding the problem. If the patient has hyperchloremia, then in that case, you can think of hypokalemia, you can think of renal tubular acidosis. So that's why the reason I do ask, yes, have you done calcium? Because anesthetists may recruit to take this patient for PNLN or stone removal for any procedure, because there may be hypercalcemia. So I will like to emphasize serum calcium phosphate must be done along with the serum protein, and the reason they know how the serum protein or albumin has got association with calculating hypercalciuria or not, there is a serum hypercalcemia or not. Second point I would like to tell, actually the practical point, which is not practical, is the trace element. It has been found that the Goldsmith worker, the professional, some professionals are predisposed for stone formation. And it has been found that Goldsmith, they got exposed to the fumes of cadmium. And cadmium is a toxigenic to the tubules. That can lead to stone formation. Many trace elements have been found, which have been found to be hazardous, like fluoride has been implicated in one of many, I think, study from Udaipur group, Dr. Tevatia and Dr. P.P. Singh. They have studied, they found that fluoride can be one of the, another factor other than fluorosis of the dental fluorosis. It can be implicated in stone formation in Rajasthan region. So there may be so many things. Trace element like zinc is an inhibitory. But fluoride, cadmium, they are again
again are promoting factors. So many promoting factors and unity factors are known. But again, I will like to say those things may be avoided for the cause of concern, which had been applied by me and Professor Shivam earlier. So we may be doing basic metabolic workup so that that can be a pointer to for the investigation. The patient's serum calcium should be done repeatedly, maybe two times, so that you can catch the hypercalcemia. And if the patient has hypercalciuria and you find the patient has multiple stone and calcification of pancreas, then in these cases, invariably we have seen patient has hyperparathyroidism. There are few markers, clinical markers there of hyperparathyroidism, which I think you can go through the literature so that you can investigate them. And once the hyperparathyroidism has been detected, you can find out the adenoma, parathyroid adenoma, and patient problem can be taken care of. Because stone formation in hyperthyroid patient precedes around 40% patient, the stone formation precedes before other complication of hyperparathyroidism, like cystic bone disease and fracture. So that again can happen later on. So therefore, one should have high index of suspicion when the patient you are again treating a patient of stone disease. The patient has uric again stone in the ureter as well as in kidney. Then those are the cases where one must think of hypercalcemia again, and you must investigate 2 or 3 samples of again serum calcium must be investigated for calcium, and maybe that you can detect hyperparathyroidism in those cases. When the patient has hypokalemia, sometimes patient may present with weakness, muscle weakness. And when you have not done electrolyte, you may miss hypokalemia at the cause. So if the patient has hypokalemia and hyperchloremia, that may be one of the markers for energy-tubular resources. Again, oxalate is important. It's only in gram, 30 to 50, 40 milligram is excreted in 24 hours a day. And usually we ask the patient to take milk and milk product along with their diet. The idea is to chelate oxalate from their diet into the intestine with the help of calcium. So calcium, when given along with the diet, it again forms, chelate the oxalate, and calcium oxalate, again oxalate is not getting absorbed from the intestine into circulation. So another important aspect is when you are not doing metabolic workup, you must again ask this patient with a calcium oxalate stone to take milk and milk product along with the diet, main diet. Not that they should take it separately, they should take along with the diet. That's also important clinical advice one must give to the patient. So I think, yes, if there is some other query, then I can reply to it. Yes, it's a very
that was great, sir. We have Dr. S.K. Pal with us also. So I would request him to just give a few comments if he is listening to us. In the meantime, Dr. Nachiket and any other faculty or residents would like to ask anything?
Sir, I think that sir has, sir, good morning. Thank you for joining us. And always grateful to sir on a personal level also, because as you know, sir, was the reason that I am faculty at SMS. So, मैं जितनी बार इनसे मिलता हूँ शायद पिछले 15 साल में, तो ये बात जरूर कहता हूँ कि whatever I am today, besides my parents, is on account of the benevolence और इनके आशीर्वाद की वजह से. I remember when I was a resident in BHU, sir. Then at that time, sir had presented a paper in AUA, sir, if I am not wrong, sir, करीबन 2001-2002 में, and that was also upon the etiopathogenesis and the role of nanobacteria inside stone formation. So, sir has been very active, and I think that he's passionate about this topic in particular. And I only want to add one thing that I think that very little has been done in genetics. And as both of you were pointing out, why it happens that 4 people in a family, they are exposed to the same environment, same food, same water, but one person is a recurrent stone formation former and the rest of the 3 are not. That still remains an enigma. And I think that both of you have, it was a very excellent summary of the things that sir has given and you have given. And thank you so much for coming, sir.
Thank you very much. Thank you all. I feel excited. And really, I thought I feel happy if I could deliver something to the again future generation. I feel very happy. Thank you all. Thank you all for giving this opportunity.
Thank you, Dr. S.K. Singh,
all.
for giving us Nachiket to our department.
Always, sir.
Always with you.
Sir के आंसू
Yeah. My origin is from Rajasthan. So I do feel very much
listening to us. He may just give his comment. Otherwise,
Thank you,
I would request Dr. R.D. Sahu to give a vote of thanks and Dr. Pal is there.
Yes.
Dr. Pal, go ahead, please.
Yes. Dr.
Please.
Pal,
It has been
We would like to
listening.
see you. Put your video on, please.
Okay.
we want to see you, sir.
I'm putting it on.
That's good, sir.
Great,
That's
sir.
good.
Hello.
Good morning, sir. Good morning.
Good
It
morning.
has been pleasure to listening to all of you, and almost everything has been covered. Hello.
Yeah.
Yes, sir.
Go ahead. We are listening.
Almost everything has been covered. The only two practical points which I wanted to mention was that renal tuberculosis has been seen to be associated with urolithiasis.
Right.
So we should also investigate on those lines. And another thing is, as Dr. S.K. Singh has pointed out, that it should be a periodic or it should be a continuous process of drinking water. So I always tell my patients that whenever the bigger needle comes on 12, means every hour you should drink 1 glass of water. And when you are awake only for 16 to 18 hours in a day. So you will only consume 16 to 18 glasses of water. Every glass may contain only 200 ml of water. So in the whole day, you will consume only 3.2 liters. That's all. That is still insufficient because for every 20 kilogram weight of a human being, he should consume 1 liter of water. So normally Indian people, they are more than 60, 70 kgs. So if you consume 3.5, it is just adequate hydration and another half a liter more. So they should increase the water intake with this calculation that every hour they have to consume 1 glass of water. And then every year they should get investigations done regarding ultrasound X-ray, not CT scan every year, but ultrasound and X-ray to see if there is a new stone formation taking place. And that should be done on your birthday, because otherwise you will always forget whether you got this treatment done in January, February, March or April. But once you remember that this birthday you have not got your ultrasound and X-ray done, that will be important for recurrent stone formers. So these are 2-3 practical points which I always try to tell my patients. 20 kg weight, 1 liter water, plus 500 ml more. As long as your kidneys and heart are strong enough, you should consume this much of water every day. Lastly, again, re-emphasize that tuberculosis, about 10 to 15% of renal tuberculosis patients will have stone formation. And still in our country, tuberculosis is very common. All other points have extensively been covered by both of you. Salutes to both of you. A very good seminar. I have learned many new things. Thank you.
Thank you, sir. Thank you, Dr. Pal, for enlightening us about that. Renal tuberculosis and the fluid that should be taken. Dr. Singh, your last comment and then we'll wrap up.
Stone is an endemic problem and the prevalence is from 5 to 10%. See, during lifetime, around 10 of us, we are going to develop stone formation. So it's important, again, disease burden. So that I will like to highlight at the end. What I will like to say, the residents and youngster, whenever you are treating the patient, get involved. How can you address his problems? And how can you can be helpful as an expert and professional to serve them, to serve the humanity and the humankind. So that is my last message. Thank you all, and a privilege to have seen all of you. And I'm very happy. I am going to have a very good day because I'm excited. I was thinking of joining you from a study again in the night when I slept. Oh, morning I have to join there. So I have operation theater and I have kept the case by 9:30 or so. So thank you very much for giving this.
Thank you, sir. Thank you.
Have a nice day.
Dr. R.D., just give vote of thanks and message.
Thank you, sir. On behalf of our department, I convey my sincere thanks to Dr. S.K. Singh, sir, and Dr. Pal sir for joining us. Thank you, sir. Thank you very much.
Thank you. Thank you once again.
Have a nice day, all of you. Yeah,
Have
thank you. Bye. Bye. Bye.